Okay, so thank y'all all very much for being with us this morning. This is our 8th annual Telehealth Summit for South Carolina and our very first virtual summit. So we're having to do things a little bit differently, but we appreciate your time. And I think it is very important during this summit that we hear from our rural leaders and our rural communities to find out how you're using telehealth, because I think that's the whole reason that Palmetto Care Connections started, was to make sure that rural residents have access to care. So if we could first get started, we'll go Miss Ann, you, then Pam, you, and then Dave. We'll let the ladies go first. If y'all could just tell me a little bit about yourself and your organization and your community.
Sure. I suppose I begin with this. Hey, I'm Ann Lewis. I am the CEO of CARE South Carolina. We are a federally qualified health center up in the PD area, which includes the counties of Dillon, Marlborough, Chesterfield, Darlington, and Lee. We're in the very, very rural areas. I've actually been the CEO up in this area for going on 40 years. Boy, that is hard to believe. We're a moderately sized FQHC. We have about 570 staff, but we've got 14 locations scattered all across those 5 counties and serve. Well, frankly, we got hit a little hard by COVID, so our patient number has dropped. But normally we serve about 38,000 patients. Thank you, Palmetto Care Connections, for inviting me to be on this panel. It's a real honor.
Well, thank you. Ms. Pam, you want to tell us a little bit about your community and your organization?
Yes, I'm Pam Davis, CEO of Little River Medical Center. And Little River Medical Center is mainly located in Little River, but we have sites scattered throughout Horry County. But we serve parts of North Carolina as well in Brunswick County and parts of Georgetown County for dental services currently. We serve over 35,000 patients a year, about 145,000 visits. We have currently about 350 employees. 6 major sites across the county. We're in 26 elementary schools now for school-based dental services. We're in Head Starts in Williamsburg, Georgetown, and Horry counties, and also doing dental services for another FQHC in Georgetown County as well. So we're familiar with driving around in rural communities with the buses, with connectivity issues, and what we have to do to get Wi-Fi service out there. But again, our county has Myrtle Beach, it's metropolitan, but we've got pockets of poverty in rural areas like in Longs, Loris, outside of Conway, all over the place. So it's needed. We still have bandwidth problems in those very rural areas, no matter where we go. It's limited, it's spotty, it disconnects at various times.
Dave, you want to tell us a little bit about yourself and your community and Hampton Regional?
Sure. Thank you, Kathy. My name is Dave Hamill. I'm CEO of Hampton Regional Medical Center. We're located in Barnville, South Carolina, which is about 50 miles inland from Beaufort, South Carolina. And we also serve a very large rural area. It's very impoverished. It's medically underserved. So we have all these challenges as well. We've got a great little health system here, and we appreciate the opportunity to participate in this conference.
Dave, you may want to speak a little bit about, you have sort of a unique situation where MUSC has invested some resources and some staff, personnel, and infused a lot of telehealth services into Hampton Regional. Would you tell us just a little bit about that?
Yeah. In May of 19, we executed a long-term affiliation agreement with MUSC Health, and the driving force of that agreement is to help bolster the level of services that we are able to provide here at Hampton, to infuse telehealth into our service lines, and so far it's been really good. We've we've got just a few of the programs going, got a few more to start in the next 12 months. And it's been an interesting experience, not without challenges from time to time. It's very, very difficult for an organization, I think, as large as MUSC to understand the challenges of a facility as small as Hampton Regional. But it's working. We've got a great dialogue with the university, and I'm thrilled about all we've been able to accomplish so far.
Well, we're hoping that will somewhat be a model for the state and a way for other rural hospitals to receive more services. So, Miss Ann.
That's one of the objectives of it, so.
I hope so. So could you speak a little bit about, were your organizations doing telehealth prior to COVID-19? If you were, did you exceed your level of expectation for telehealth once COVID hit? And how has that exploded, or has it exploded in your organization?
Honestly, it was a little bit here and a little bit there. It wasn't, I would say, a tsunami. That changed. Everything changed. In short order, I've heard other people describe it this way, and I would too. We probably did 5 years worth of telehealth implementation over the space of a month. At one time, 80% of our visits were by telehealth. And that's not only medical, but also behavioral health. Behavioral health for months was 100% telehealth. We even had dental telehealth visits. So it galvanized, and by it, I mean the coronavirus, this use of telehealth. And it frankly, it has dropped off some. We've been able to get back into some offices, as many organizations have, but it's still a preferred model of connectivity with your provider for a lot of patients. So although we've seen a drop off, it's still going to be a way that we look toward the future. We actually are adopting a mantra that says, the office visit is a dinosaur. And telehealth is going to be a really important tool that we'll have for the future.
Ms. Pam, how about you? How did telehealth, were you doing telehealth prior to COVID? And how did things change once COVID hit?
Yes, prior to COVID, we had the behavioral health telehealth carts that we had early on purchased in a program working with the local drug abuse association for expert. And so we could get the substance abuse services and counseling for patients. So we had those old carts a long time ago, and we had received a grant and had purchased the new Iron Bow carts that we were placed at all locations. And then we had planned to go into the schools with those. So those had peripherals, so we could hear and see and have the cameras and everything included for the provider that needed to really assess the patient further than just looking at them. We had tried to do that early on if a provider was out sick, and then another provider at another site could pick up some of those telehealth visits. Providers were sick and at home, but yet not sick enough that they couldn't do telehealth, so they could pick up their patients. Starting in January in 2020, we had moved into the schools to do sick care during telehealth. Just had got that revved up and the training done and everybody going, policies developed, had seen a couple of children and getting people enrolled, and then COVID hit. So then we had to backtrack, but we were set up for COVID pretty much. We had the equipment. We had already purchased the monitors for physicians to interact with the school. We had already purchased those for the behavioral health to interact. We just had to go back around and retrain now, because if you don't use it often, they forget how to use it. The nurses didn't remember how to connect. The providers forgot. And so with the platform we were having to use, we have a new EMR. We went to Hilo, and the Hilo at that time required an email address. address, which that's another complication. A lot of people don't have emails. It takes a while to set them up, and then they don't remember the passcodes. So as this has progressed, Hilo has progressed, and now you don't have to have an email address. You can just launch it, put the patient in the schedule, and the patient gets a link to log in. We also use DoxyMe. That was actually preferred over Hilo because it didn't require an email. It was very quick, and it's now free. We don't know if it'll stay free long term, but that was one way to get connected very quickly. We've also, the least from a favorite is to just use the telephone in calling the patients. We have some patients that, try to use FaceTime, and that's, it's not secure, so we don't like to use that version of the only other downside of the Hilo is the cost is $2 to use it right now, and it could go up after COVID, and that was the plan before. Is it going to be we're priced so that you can continue to move forward? Also, with that, we've entered contracts with MUSC to have the telepsychiatry. It was slowed down our process during COVID. It's going to be gearing back up in October for adult and children, so that our patients on site would have access to the psychiatrist down at MUSC. Also, through the TACM program, we had that limited monitoring program. So what we are looking at now is how we did buy some of those portable carts to go into the home for peripherals. So during COVID, we weren't sending people out in the community very much, but we're looking at now, children are not coming in. They're not getting those well visits. So those difficult ones, we need to attack, send the nurse out with the peripherals and try to get those well child checks done. So that's what we're looking at now, and a master plan of how to do that moving forward, especially since in our county, there's over 14,000 children that are 100% virtual. So they're not going to be at the schools for us to catch them for sick care. They're still parents with work problems and transportation issues, still aren't bringing them to the office. And so if we're going to try to keep them healthy and meet our quality measures, we're going to need to reach out.
Dave, how about you? I don't know if things have changed for you or if you're just sort of on the track with MUSC and things are kind of the way that they were supposed to be, or did you implement new services due to COVID?
Kathy, we've implemented a lot of services with MUSC. We haven't really stopped progressing through that. We're providing endocrinology and cardiac services on an outpatient basis now, and on the inpatient ER side, we have pediatric intensivists, of course, telestroke and neuro, nephrology, and our hospitalist services are provided via telemedicine. We added a very robust teleradiology service right before COVID hit, and that has been a huge improvement for the services we provide here. And pretty soon we're going to be adding tele-ICU and infectious disease. We did ramp up virtual care, both through our own platform and through MUSC. As when COVID presented itself to us, it's been a real challenge. I think everybody has expressed already the very significant drop-off in outpatient services, but we've also seen that in the emergency room, and I think that's consistent with all the hospitals in the country. We're all wondering where all the strokes and heart attacks have gone, and other serious illnesses. But we're starting to see it come back a little bit. We're starting to see people not so questionable about telehealth, and we did a few FaceTimes like some of the other folks have done, but really we've tried to use our virtual platform for teleconsults on the outpatient basis.
I think, Ms. Pam, you mentioned doing some visits over the phone. So I know that CMS, they loosened the reimbursement quite significantly during COVID, and they allowed for phone visits to be reimbursed. And I remember looking, Miss Ann, at Care South's numbers, and y'all were doing probably a little more phone versus virtual at one time. And I'm assuming that that has to do with maybe the lack of broadband in your areas and the fact that some of your patients maybe could not connect virtually. Could you touch on that for a second?
Absolutely. I know that this is going to be hard for everybody to see, but this is a map that comes straight off of the Palmetto Care Connections webpage, and it is a map that shows broadband access throughout South Carolina. Well, if you see those pink areas, that means that the access is limited, and that's the PD. We are really, really struggling up in the PD with broadband access. Not only does it, sometimes you can't even start a telehealth visit, but sometimes you're in the middle of a telehealth visit and you lose all of the connectivity. So this is a real, real serious problem for rural areas. And like Pam even mentioned, there's pockets, but we have up in some of our counties, almost the whole county that has limited access. We have implemented these sprinter vans. Think the way an ambulance looks. That's what we implemented to spread out testing. But these sprinter vans, we also call them Mobies, are also Wi-Fi hotspots that we can deploy out into some of these really dead areas. But we're having some real issues. We found a huge amount of acceptance and even excitement around a telehealth visit amongst patients. But then it would be so many problems with connectivity, frankly, that became very discouraging. So we have a serious problem up in PD.
Pam, how about you? I know that you probably have more, I know that you have pockets. Maybe it's not as big an issue for you down in Ouray County as it is in the PD area or in the Low Country.
Well, you have an issue where they can't afford the internet, and they don't have a smartphone. We have got patients, especially in the Ryan White program, they don't have smartphones, and so you're going to have to call them. There's no other way to do it, and since they're at their health risk, you don't want those patients always coming into the office. So there's going to be patients, cancer patients, various patients that are still going to have to either connect by phone if they don't have internet and can't afford it. And you mentioned in the elderly at some point, but some elderly are not tech savvy, and some have smartphones, but they still don't know how to use them. So the link we send out has to be very easy, and definitely don't tell them to do an email address because you're not going to get it, or help them set it up. We've tried to figure out how do we save passcodes, not for any other use, but they don't remember anything. So we have to try to remember it for them and help them along the way. But that's the biggest thing is almost everybody does have a smartphone, but there are people that don't and don't want them. And don't want internet and access to it. So we're going to be facing that. Our biggest challenge now is not only just because of COVID, but because the school's not going back and being virtual, and the children being at home. The parents have kind of gotten used to, well, they're going to be at home. Well, they don't need to go to the doctor. They don't need to go do all these other things. And we've got to kind of reverse that knowledge. We're trying to educate the community that we're safe. We do have our patients that have symptoms separated. They're not in the main office. If you want to come in our parking lot, sit in your car in your parking lot, we will connect with you, launch you. My nurse will go out with an iPad. We'll bring the telehealth card up if we have to. The doctors will garb up and come out. It just depends on the need. If it's a sick child, the peds will walk out there and see them. So we don't make the patient come in if they're not comfortable. We're now do curbside pharmacy delivery services and administration. We're now going to be trying to do telehealth with flu shot clinics, combined with also giving them the fit for the colorectal fit while they're there to take it home and get that. So we're thinking out of the box of how else can we drive them through, not just get your COVID test, but you got to get all these other things that are missing. Let's get that checked. And we had written another grant, but we didn't get funded for more telehealth equipment. And that included more things for the blood pressure monitoring, glucose monitoring, for those patients that need that service to transmit back to us, even if they don't have a cuff at home, or maybe we just provide them with a cuff so we at least know how they're doing.
Dave, how about you? I'm assuming that broadband has been a significant barrier in your communities as well.
It is in a lot of areas of our service area. You know, it's incredibly frustrating, and you know, we have trouble keeping track of our patients anyway, especially more of the impoverished and underserved. Their cell phone numbers don't stay consistent. They've got, you know, a different number every week sometimes, or every month. But lack of broadband is a challenge for all of us. There are parts of the county where you can't even get a cell signal, and that's disheartening. I think we're making progress, but it's a long ways from being where it needs to be.
Another issue we see, Kathy, is if it's chewing up their data minutes, the patients don't have a lot of data in minutes. So that's a limiting factor right there. Even though we've tried to develop the electronic signature for consents, and we can send it through jot form and they can sign it. Well, it's how much data is it chewing up on their phone. And so it might be completed, it might not be. So a lot of those issues are.
So right before this interview, I interviewed one of the FCC commissioners, Brendan Carr, and they have a new program coming out in the fall called the Connected Care Pilot Program. Each of you will be receiving an email, but it is funding that will allow a healthcare provider like yourselves that already participate in the FCC Healthcare Connect Fund to be able to pay for internet services for your patients.
Oh, good.
We will be sending each of you a survey, hopefully today, that hopefully we as a state of South Carolina can come up with a couple of programs that we would like to provide to the patients. And hopefully we can select some of those patients of yours to be able to get internet. So the FCC does have several programs. One of those programs is the Lifeline Program, and it provides subsidies to low-income households. We are hopefully going to do a study in this state. We only have about 20% of eligible Lifeline recipients receiving those subsidies. So we will provide more information to you guys about that. But once we can identify and maybe do some patient education around some subsidies that these low-income households can receive. So that's
Is Lifeline also the one that provides the cell phone service of cell phones to patients as well?
Yes, ma'am. Yes, ma'am.
Lifeline.
And most of those are not smartphones either. So they could upgrade the phone situation.
Yes. So the other thing I want to ask you about with patient education is, do you see a huge need for patient education around telehealth, around broadband? How best could we help provide that education to your patients, whether it's your elderly patients or whether it's your patients that maybe have a low educational level, and maybe we need to provide some education to them? Do you see that as a huge need?
You know, right before coronavirus, at the end, in the middle of 2019, we were having a lot of discussions with MUSC and with y'all, with Palmetto Care Connections, because just like Pam described, we had wanted to be able to use telehealth in locations between our sites, so that if a provider was very delayed or wasn't even in an office, that they'd be able to connect with another provider. And at that point, patients did not want to do that. They did not understand what telehealth was. They were willing to wait, you know, however long it took to be able to see their own provider. I really have to say that I'm not so sure that that is needed anymore. I think the biggest need we're going to have is like technology, this very, you know, how to connect, where all the buttons are, you know, just
That's the biggest thing.
The mechanics of all of this. I think that's the biggest thing. I think we have created a groundswell of acceptance around telehealth and how it really is a good tool to connect patients and their providers. But it's that technology that gets us every time.
So maybe more of a digital literacy campaign, which is something, Miss Ann, that you know that Palmetto Care Connections has been working on and trying to provide that to communities across the state. So maybe sort of a digital literacy. How do you use the computer? What is the broadband? How, what is internet? Are they the same thing? So is that the kind of education that y'all feel like maybe needs to be provided?
Well, there are people that still don't know how to use a computer at all. So if you got them the internet, as long as they can have Wi-Fi and that helps with their phone picking up, that might be better. A lot of people can use a phone better than using the computer. So if you send them a link and they can easily click, that's faster. If you try to tell my mom how to turn a computer on, you can forget it. You're not going to get it. So she knows how to do her phone, and she can click the buttons on that, but don't let her go near the computer. So I think trying to make it as easy as we can for meet them where they are. If they need that, if you can put the internet, but if they still don't have a computer, it's still not going to work unless they have a smartphone. So we have to have that ability to give them the technology and then show them how to turn it on and use it, because they don't know how to troubleshoot a thing. So a lot of times our nurses reach out to the patients ahead and help them troubleshoot before that doctor tries to get on the line or the day before, so that we can make it a lot easier for them.
Yeah. I think you're on the right track though, Kathy. I think digital technology training, we've had better success with tablets than with like computers and laptops. And of course, like Pam is saying, the cell phone, but I would really echo that.
Okay. Dave, you agree with those sentiments?
I do. We've experienced the same things that the other folks here have talked about. I haven't really come across any real reluctance, at least that's made it to my desk, of patients not wanting to do telehealth. I think COVID kind of pushed everybody into saying, yeah, well, let's try it, because I really don't want to go to the doctor's office. But again, the lack of technology in our service area, the lack of broadband or even consistent cell service is a challenge. When you're in the community, like here in Barnville or Hampton or Estill, yeah, you're good, but in between there, some places you're just out of luck.
Yeah.
Well, we did implement a survey to our patients. So we do surveys quarterly anyway. So we added a question about the telehealth. What was the likelihood to schedule a telehealth visit after the pandemic? 70% responded that they were more than likely or very likely to use the services again. So I think more people do want it, and we've either got to get on the bandwagon and make sure we have a payment for it, because after COVID, we've got to ensure that we still could get paid and reimbursed for the actual cost of this, not at a low level that you can't afford to still do it, because we still try to do everything that we normally do in a visit on the phone. And sometimes it takes longer because of the connectivity issue that we're spending with the patient.
Pam, you hit on my last question. So prior to COVID, I know that rural health clinics and FQHCs could not actually bill as what we call a distant site provider, which means you could not do direct care to your patients. And that changed during COVID. And I have seen in some congressional legislation that they're trying to keep that verbiage so that you can continue. So the advocacy level that we need is going to be significant to make sure that you continue to get reimbursed. But hopefully we're also going to submit a parity bill that I hope all of you will support to our legislature in early January, because I think that's needed, because some of the providers, just like you said, Ms. Pam, they may want to pay less for a virtual than they pay for a face-to-face, and you're nodding your head. So I'm thinking that you believe we need to have the same payment virtual versus face-to-face. Is that correct?
Yes, it's taken us longer to do these kind of visits because of the needs of our patients. They're not that simple. It's not just say, how do you feel today? Okay, I'll call you an antibiotic. That's it. Our nurses still engage the patient ahead of time. We're still going all the health history, doing all the education, everything we would have done. And then we try to pair it too and streamline them to get them in for that lab and everything else, because at some point you still have to get some of those on-site services done. So that's vital for us and survival of this.
This parity issue, particularly pertinent to the private insurance industry. I've been amazed and astonished and appreciative around Medicare and Medicaid. But let's make sure our private insurers are really up there with it too. So that parity is going to be really important. You know, we have created a script in our call center that we actually, when a patient calls for an appointment, we actually offer them a telehealth appointment first. And we're getting a big response from that. About 50% will accept a telehealth appointment. We can't go backwards. Once this public health emergency is over, if it ever gets over, we can't go backwards. That's just imperative.
Well, it does help free up your office for the really needed visits, and if quick things could be done through telehealth, that would be much easier.
Well, I think so. You've all sort of answered my question. I do believe that after COVID, telehealth will remain a part of your practice. We just need to come together and collaborate and make sure we advocate for that continued reimbursement, not only from the federal and state level, but from our private insurers, which is probably going to be a little bit more challenging. So we may be reaching out to all of you to maybe sign a letter or serve as an advocate as we push for that parity. Any last words about telehealth, broadband, anything that we haven't touched on today that maybe you need assistance with or your patients need assistance with?
I do think there's a need for expansion in the Medicaid dental area for telehealth, because right now you can only do that if the patient has an appointment for an emergency visit. If we're doing telehealth, we need to call those, like these children. We know they had an issue, they needed a filling or an extraction, but they're not coming in. That doesn't count. They are not scheduled for an emergency visit yet, but we know they have a situation in their mouth that's going to lead to that. So we should be able to call and be able to assess, but that's not included as part of telehealth right now. What we're finding is that when we call ahead of time of an emergency visit, they don't show. They talk to the doctor on the phone. Then they don't even show for the appointment, and still in need of that emergency service.
I want to really push for in-home monitoring. I know that that's almost like a little side part for telehealth. It kind of exists out there in the virtual world, but in-home monitoring, I think, is a really, Pam mentioned it, and I think many of us are beginning to dabble in it, so to speak. But I think this is the next frontier where we can really begin to make a difference. When you begin to combine in-home monitoring with telehealth, you've really got something there that has a massive potential of doing what my vision is, making the office visit a dinosaur. So I want to really push for that as a virtual options.
Well, I'm glad you said that, Ms. Ann, because I think that can be the basis for our statewide connected care application that we submit to the FCC. So I think Davey is letting me know that our 30 minutes is up, and I want to thank each one of you. I know you have a busy day, a busy week, you have a lot going on, and just to take the time to let folks know what really telehealth has brought to our rural communities and what our needs are. I want to thank each of you for your time today and let you know that Palmetto Care Connections, the Office of Rural Health, Hospital Association, we're there to serve as your advocates, and reach out to us if there's anything that we can do.
Thank you.
Thank you.
Thank y'all so much.
Thank you, Kathy.
And have a great weekend.
All right. Thank you. Bye.
You too. Bye-bye.
Bye.